I'm a Ngambri woman of Ngunnawal speaking and the Walgaloo, and on my mother's side, Wiradjuri, a wonderful nation. I have 4 children and 12 grandchildren and 5 great-grandchildren. So I'm pretty happy to know that my family, through this research, can be helped like thousands and thousands of other Aboriginal and Torres Strait Islander people. And that's what it's all about, our families. But today we're here to celebrate this wonderful institution of the job that it's doing now. And to thank the panel for being here today as well. And to thank you, Rom, for asking me. Are you still there? Yeah, okay. Thank you very much and welcome.
Matilda, did you take my notes? So I thank you for giving back the notes, and I thank you for the welcome. When Matilda gives a welcome to country, it's much more than a welcome, as you've heard. So thank you, Matilda, for your generosity, your time, and also the reminder, I think, that this is a collaborative piece of work, but Aboriginal people, Torres Strait Islander people really need to be driving the agenda, setting the agenda, driving the agenda, working with others, and they're the benefits that will accrue for our people. I also want to acknowledge, after you, Matilda, you mentioned Lowitja O'Donoghue herself, who's just not only an amazing person to have given so much to the country, but to have gifted her name to the Institute. And along with that comes a whole set of responsibilities for us, acutely felt by our chair, Pat Anderson here, who will be launching one of our reports in a little while. Pat, the board and I, all of our staff are very clear that Lowitja really compelled us to be courageous in this space and to actually do things, to act in tangible ways that benefited our people. So this exercise here today is, much more about the work that proceeds in so many different places, what we can all learn from that, translate for ourselves into our own settings to deliver better for our people. And this is a great line-up here today, and I acknowledge all of the panel members who have travelled to get here and to share this time with us. Kim O'Donnell, who is Dr. Kim O'Donnell from Flinders University, South Australia, couldn't be with us today, and she sends her apologies. Kim is a Barkindji woman who sadly has to return and has returned home often over the past couple of years through losing a close family member. So Kim's certainly with us here today, and Judith will be covering off on the program that Kim would have spoken to. Actually, I might just talk about the Institute itself and the sort of work that we do and what we're guided by. So clearly Lowitja is at the forefront of our thinking and doing. But we have 5 research principles that we want to see in all of the work that we're involved in, whether it's through commissioning or working with others in partnership, whatever that might be. So the first is to act for the benefit of Aboriginal and Torres Strait Islander people in the conduct, in the facilitation of our research. So that's a benefit agenda. If we're not clear in the discussion about what the benefit might be, and this is Matilda's point about, who's benefiting? Are we churning through more careers and PhDs, or is there a tangible or an accrued benefit for our people? And they're not. There's actually not a polarity there, and I apologise if it's heard in that way. Leadership by Aboriginal and Torres Strait Islander people. This is another principle. Engagement of research end users, and this is typical of research activity. But we want to give prominence, and we've got prominent people here today, particularly our communities, our services, our mob on the ground, our families. The development of an Aboriginal and Torres Strait Islander research workforce, fundamental. In the same way that we're building professionals across a range of careers, we want more of our people in higher research degrees, and the pipeline and the pathway right throughout to deliver that for us. And I've alluded to it already, but the measurement of impact for any number of reasons. And we need to be able to answer those questions for our own people, but also answer those questions to policymakers, funders, etc. So an impact agenda is fundamental. So with that, I might now go to the panel. We have, as I've said, three amazing people on the panel. We'll speak to 3 projects. The brief for the panel is 10 minutes, really to talk about their perspective on the work. And after the panellists have had an opportunity to provide their perspective, what I'm keen to do is to have an engagement. Reverend Les Baird is an Anglican priest in Yarrabah. Les is the Indigenous Mental Health Suicide Prevention Coordinator at Wontock College in Cairns, and has worked on building family wellbeing, the family wellbeing program into the curriculum of the Cert 4 in Indigenous Mental Health, specialising in suicide prevention. He specialises in the development of Aboriginal and Torres Strait Islander leaders from his community, and has been instrumental in the positive change process in Yarrabah over a number of years. And Les, I just want to read this out, if I get the right report. Where is that report? Matilda, have you got that report? Oh, here it is. So this report, the Family Wellbeing, Empowering Aboriginal and Torres Strait Islander People to Bloom and Grow. In this report, Les, and I have got Les's clearance to quote him, Les said, and I quote, "Many changes started to take place eventually in my life." This is after having been a part of the Family Wellbeing program. When we were doing goal setting, which is an element in the program, when we were doing goal setting, there were 2 goals I wanted to achieve, and one of them was to get my master's degree, which I've just completed and graduated in May this year, and that was last year. So, wonderful. So I did want to acknowledge that here today. So Family Wellbeing is an effective social and emotional wellbeing program originally developed and delivered by and for Aboriginal people and Torres Strait Islander people in South Australia. Back in '93, the Aboriginal Employment Development Branch of the South Australian Department of Education. And the central objective of the program, Family Wellbeing, is to develop people's skills and capacity to move from a position of disempowerment to empowerment, to take control and to change their lives. So over the past 20 plus years, the program has continued and spread with little formal support, but there's been a proliferation of this program, and it's now nationally active across most states and territories, along with some international uptake. So we've got this homegrown program, organically grown and overseas as well. So Les, if you can join with me in welcoming Les here today.
Hello, is this on? I'd like to acknowledge Romley and Pat for Lowitja Institute, and thank you for bringing me here to this panel. I'd also like to acknowledge the traditional owners of the land in which I talk, and I'd like to thank you for allowing me to be here to talk. It's a bit difficult to talk about 10 years of work with family wellbeing in 10 minutes. So I'm just going to give you just some case studies, including mine, as a result of family well-being. I was the health manager for the development of community controlled health services in Yarrabah, which is now called Girinya Yilamaka Health Service. Family well-being was introduced into Yarrabah through the men's group in 2001, and I was a part of when family well-being was introduced. We were introduced into the first stage, and the first stage covered a lot of the topics that was affecting our people and had issues to it. The topics were leadership, basic human needs, relationship, and when we went through basic human needs, one of the ladies who lived in a tin shack house outside of the community with all of her kids, and some of her kids were sick, she came to do the family well-being, and as she looked at the basic human needs, she seen where she was lacking, and she didn't have proper housing for her kids. So before family well-being, all she used to do was complain about the council is not doing anything for people living on the outskirts of Yarrabah, because there's many people live in tin shacks on the outskirts of Yarrabah. So when she came to know family well-being, and she was empowered to start to do something, and so she started writing letters to the council about her condition, where she was with her family, with sick members of her family in a house. And council started to listen. The area where she was, it was outside of the town council boundary, but then they extended their boundary out to her area where she was. And what happened after that is the council was able to take her and move her into a demountable house, which was at least a beginning step for her. And then now today she lives in a brick home, provided for by the council. And so that's proof about the family well-being program, that it has a powerful effect on people. One of the men from men's group, in communities you have some men who have lots of alcohol and drug problems. One of the men who came along and started the family well-being program, although he still drank, he made decisions. He looked at his life journey and seen where his life journey is, and he made decisions about purchasing a car and a boat and taking care of his family. One of the other guy, my sons from men's group, he wanted to do some university studies, so he did his graduate diploma in Indigenous health promotions at Sydney Uni, and he graduated with his diploma. Myself, I failed second year high school. I didn't complete second year high school, and I never used to think that I could do anything. But when I came into knowing family well-being, looking at my life journey and where I wanted to go, there's two things that I wanted to achieve, and that was to finish uni and to write a book about my work in Yarrabah. So in 2012, I went to Sydney Uni, did my diploma in Indigenous health, specialising in substance use. And then 2013, I did my master's degree in Indigenous health, substance abuse, and then I graduated from Sydney Uni in 2014. And so the program of family well-being has a direct effect that can lift you up out of poverty and put you into a place what people take for normal, like the lady getting accommodation, the men dealing with some of their issues. My son had domestic violence issues, and so he had to deal with those issues. And it is through the empowerment, like family well-being is a program that empowers people to think about their issues and to start to deal with their issues. And then they're able to look at how they're going to plan for the future. What would they like to do for the future? And then like further development, like my son went on to developing a men's dance troupe, and they wanted to provide, like do professional dancing and to be able to bring in tourism into the community. And so I worked very closely with the men's group on culture, you know. And so it's all these works that came out of family well-being. And I think family well-being, like it's not going to go away, it's going to grow. And I've attended the family well-being roundtables in Adelaide and in Melbourne, and this is out of the recommendations. One of the recommendations is speaking to policymakers, and this is, you know, I think Lowitja Institute, you know, has a big role to play in research, because like when I first went to Yarra to be engaged in research, the people said, "Why research? You know, what they're not going to get their PhD and they're just going to leave it on the shelf. What's going to happen to us?" And so I became engaged in participatory action research, you know, and with Dr. Kamala Say and his team, with Janya, Mary Whiteside from Melbourne University, with all those good people that we work together. And, you know, like our community needs something, and family well-being covers two things. It covers personal healing and empowerment, and it builds the capacity of people to think about to think about their life and what they need to do about their life. And I'm grateful that, you know, Lowitja is playing a major role in promoting the family wellbeing program, because through the Adelaide conference, we were able to come together with researchers, policymakers, and discuss about the different like family wellbeing programs happening in different parts of the country. And you could see out of the success stories how successful family wellbeing is. Thank you.
Thank you, Les. We'll take questions later, I think. We'll have all of the panellists deliver their thoughts. But we can kind of, you know, we hear and observe and see very clearly the negative discourse that is ubiquitous in this country at every level. And what we hear about here is something very tangible, very successful, empowering. So these are the sorts of things that certainly the Lowitja Institute will want to hear more about, and how do we get that message out. And thank you, Les, for acknowledging that we might have a role in that into the future. Now, Cleveland is a traditional owner from the Kuranda, Cairns and Cape region, and believes in Aboriginal and Torres Strait Islander people creating their own solutions to overcome everyday disadvantages. So currently the CEO of Apinipima Cape York Health Council, he has been working towards the key aim to improve health outcomes of people across Cape York. Cleveland has extensive experience working in Aboriginal and Torres Strait Islander affairs across governments and non-government organisations. Now, Cleveland's contribution today will be about the Funding Accountability and Results project, which will be launched today. And there are 3 case studies in that piece of work. So the FAR project was an extended observational study of reforms in the Northern Territory, Cape York and Cape York, Queensland, that aimed to transfer primary healthcare services to regional Aboriginal community-controlled health services in a partnership approach between the sector and the federal and jurisdictional health departments. The project's conclusions call for a resetting of the relationship between the sector and government so that it works well to meet the needs of both funders and ACCHOs, and most importantly, to enable universal access to comprehensive primary health care for Aboriginal and Torres Strait Islander people. So please welcome Cleveland.
Thanks. Hello? Yeah, thanks, Rom. I'd also like to acknowledge traditional owners and thank the chairperson, Pat, and Rom for giving me the opportunity to talk here. I was just sitting there listening when Rom was introducing me, and I just recommend don't let other people do your biography, because it just sounds so wrong. I mean, yeah, I just would have had works at a Punapima and left it at that. I've been working probably in the health sector for a long time. I remember Joy and I first sat on the board of Wuchopran. You know, spending hours late at night in board meetings and then going home to our houses and staying up till 1, 2 in the morning with our kids asleep on the floor talking around what we can do. So for me, it's a privilege to be able to sit here at the national level and start talking about some of the stuff that had, you know, seedlings a long, long time ago. I remember the first time that we started talking about the fire project, and it was with Judith, Solomon Button at the Novotel coffee shop in Brisbane, probably about 4 or 5 years ago, and talking about how what we were trying to do in Cape York, in Yarrabah at that stage, and also in the Northern Territory around moving responsibility for health services from government back to community. My organisation, as at I think last week, the 11th of November, for us has been 21 years. 21 years of an organisation that was set up by local people whose mandate was around being able to control the health of their community. So it's taken this long for us to try and get some runs on the board in that area. The fire project for me was more so a reflection on the journey that we've taken over the last 9.5 years, and reading back on, you know, when we're doing some of the proofing, it made me realise a lot of the challenges that we had, a lot of the problems that we had to overcome that are still here today. But I think what we've done is been able to be a lot more flexible and actually work around it to get the kind of health outcomes that our people need. In terms of the work that Lowitja does, within my organisation of Punapima, we place a very strong emphasis on research. Within our organisation, research is one of our 5 strategic goals that we want to achieve from the board. And the 5th strategy was around Punapima being a leader in remote health nationally and internationally. And so that's the kind of emphasis that my board places around research and what it means to us. Within our organisation, we have established a research team because of the amounts of requests that we get around being involved in research with organisations and universities. And I think at the last count we had something like 16 formal relationships with universities. Over the last 3 weeks, probably about another 10 requests have come in around being involved in various things. One of the things that was really important for us is to actually, as an organisation, know what we want to achieve, know the organisation or the environment we're working in, to then identify whether or not that research is a part of what we want to be involved in. For us, evidence has to underpin everything we do. So whether it's health services, whether it's governance, whether it's finance, HR, community engagement, we always look for the evidence to underpin, are we doing it the best way? What are the lessons that have been learnt and the things that have gone wrong in other areas? And how do we do it properly for our communities? And so we take a very strong stance on research, and then that translates into actual processes within the organisation. So when a request comes in, the first thing we look at is what is the benefit versus the effort. There's been a whole lot of things that we're asked to be involved in that is just too much. It's a resource drain on the organisation. So if it doesn't link into what we want to achieve, and if it isn't too much of an impact on our resources, then we would consider being involved. We've also got a research committee within the organisation that has representatives from our board, has management, has technical expertise, community level staff there, that then goes through and assess whether or not as an organisation we want to either support or be involved in these research things. One of the key things we do is make sure that if we do support, that there is some kind of transfer of skills to our staff or to our community members. Once we have become involved in a research, the next thing is then how do we do it? So, like I said, what's mandatory in any of our support is coming back and feeding back the information to staff. And so we have what we call a journal club, and the journal club is where we get people to come in and actually talk to our staff around research they've done, around projects of work they're working on. And it's a way then that we can actually spend a bit more time like this, asking the detailed questions to get the information we need. We also create within the organisation an authority to lead. So we wanted to turn the whole research thing on its head, and we wanted to control it and lead it. And the other thing is just how do we then start to build basic evaluation processes into what our staff do on a daily basis. And so, we become part of these research projects where it takes a long time and, they collect a lot of data. But how do we start to build that into what our staff do on a daily basis? So that's how we've sort of handled research internally. And I suppose the key takeaway messages I wanted to put forward today is that I remember talking to a Lowitja workshop, 2-3 years ago, and Lynn's in the room here up in Brisbane. And I made it very clear there that I thought that research was a waste of time. I have changed. I have started to see the benefits of it. Well, I said that because it took 2 years and a lot of resources and time and effort to tell me something that I already knew. And so that was my issue with it. But what it has done for me is actually started to put a really robust process and methodology behind what we know and turns it into evidence. So that's the first thing is, and it's really hard when you're doing innovative things to actually create the evidence base, and that's what research does for us. The second key point is that research in health is very strong. I know Nairi is involved with me on some other stuff, but at the end of the day, how strong is that research in other social determinant areas? I remember sitting down and talking to some of them mob up in Cowan there, and when we say to them, Auntie, why don't you take your tablet? Oh, because I've got all these, the kids and I'm looking after them, and my son and daughter here fighting, and we've got gambling and drinking. And so can there be the same level of rigour into research around social determinants and how they fit into health, within that holistic view, to then allow us to build the evidence and approach to then brings me to my third point then, which is then around to influence priority setting and resource allocation at the state and the national level. For us, research does two things. One, it tells you about how to do things according to what best practice and evidence is. But what we don't see is then that evidence being used in and turned around and been put into policy. I've sat down with government and presented information around, cost efficiencies, outcomes in health and in social determinants based on evidence, and none of that gets picked up. And so research to me has to be two ways. One, we use that to guide how we do things on the ground, but more importantly, it then has to be fed back up to guide what policies are agreed to by government, and then how that then informs the actual resource allocation. So, like I said, I'm happy to be here. I've really had a change in thinking around research. It will continue to be a big part of what we do, because a lot of the stuff that we're doing is very innovative, and the only way to get that set down and accepted by external organisations is to have that seen as evidence, which is what the research process can do. Thanks.
It's fantastic, Cleveland. You've just summarised precisely what the challenges are, and not just the challenges, but the business that we should all be in. What's the point of going through long-winded processes to get to something that might deliver something perhaps that someone may be interested in, but largely the translational and the implementation work, is heavily compromised. So these are the things that we want to do, is how do we, the politicians want to know about evidence, what works, what's going to have an impact, what's concrete, what's tangible, what will benefit people, what will benefit their constituencies. Policymakers, I'm sure you all share that view, that your work should have tangible impacts. There should be a benefit and impact agenda. And we've heard from Cleveland how that operates at all of the levels. So this is the business that certainly the Lowitja Institute wants to get into, not just the business of research, but that translational space, and you might even call it advocacy. You might even say that if there's stuff that we know that works, we should be singing from the rooftops as well as prosecuting it very loudly to try and get that stuff, the uptake of that evidence into policy and programs, which was your point, Cleveland, about making decisions then about priorities and resourcing. So thank you, Cleveland, for that. Now, Judith, Professor Judith Dwyer, I'm a bit hesitant now after Cleveland's. Judith works at Flinders, and Judith is substituting for Kim, as I've mentioned. Kim couldn't be here today. And the Managing Two Worlds Together project is the third stage of a three-stage project, I was going to say. So it's the last bit of a project. And essentially it says, it observes that healthcare is delivered in specialised segments and mostly succeeds or fails as a package. So you might have bits and pieces operating well, but in terms of the package, the continuum, that may not be the case. So tracking patients' experiences through the system is an effective way to evaluate how and why the package works or doesn't. The project investigated what works well and what needs improvement in the health system for Aboriginal and Torres Strait Islander people. And Judith can go into a little bit more detail around that. It highlighted the critical segments and gaps and produced practical tools that can be used by many families, patients, health professionals, etc. And at the launch of this project in Adelaide, Pat and I were at, when was that, Judith? A little while ago. Middle of the year. It's all a bit of a blur, but there was this story that was told about the continuum, the patient journey, and how we kind of, over-invest in the specialists, the surgeon. So if someone has to get from the APY lands to Adelaide for surgery, and we kind of, sort of almost bow down to these highly specialised professionals. But in terms of looking at the map, the surgeon has about that much play. So we've got to get real about where all of the things can go wrong for that patient and the family, or right, to get the optimal outcome. So it's a bit of a rewiring and a rethinking, and we've developed some tools around that. But I'm probably stealing your thunder, Judith. So Judith Dwyer works at Flinders.
Thanks, Romley. Is it working? Look, I'd also like to acknowledge the traditional owners and thank Auntie Matilda for her welcome, and also for speaking to me, because I am one of those white academics. And I want to say one thing about that and about working with the Lowitja Institute, and that is that what the Institute has given me as a non-Aboriginal researcher is a proper authorising environment in which I can know that what I'm doing is at least relevant to the knowledge needs of Aboriginal organisations and communities, and at best might be helpful. So I'm going to talk about the Managing Two Worlds Together project, and the problem we were funded initially by the South Australian Health Department to look at what goes wrong and what might work better in the care for rural and remote Aboriginal patients who needed to come to Adelaide City hospitals for healthcare. And we knew that, you know, country Aboriginal patients in particular are missing out. They get their care later. There are missing patients. You know from the data that there should be more people coming for things and they're not there. They presumably have given up on getting care, and there's hardship for the patients. And whenever care goes wrong, there's a lot of waste for everybody. So that was the problem that we set out to look at in this project. So these patient journeys that rural and remote Aboriginal people go through, they're the most complicated patient journeys you could ever wish for, really. And we knew from the beginning that we needed to focus on the whole care journey for the patients. As Romley said, you know, the healthcare succeeds or fails as a whole package. We also knew there were so many sort of factors swirling around that impact on how that care works and what it's like for the patients. We knew that we had to develop some frameworks for understanding and analysing the many kinds of issues that affect the journeys, including the broad social factors, the health system factors, and also the full dimensions of health, of what health means for the patients. And there's an important distinction that needs to be made here. We weren't under the illusion that healthcare providers can address all of those things. But what is important is that they be aware of them and take them into account. Because if they don't, it will affect negatively the care journeys and make the care that the providers deliver less effective. So that was sort of the first thing that we realised, that there was a lot going on and we needed to have an organised way of analysing it. The second thing we got to was what we ended up calling the complexity principle. You know, hospitals and health services are set up to deal with clinical complexity, and they've got systems and protocols in place for doing that. So what we came to suggest was that they also need to be responsive to patient journey complexity. Not every Aboriginal patient from the bush is going to need a tailored response to their patient care journey, but it is predictable that many people will. And if that reality is ignored and not prepared for, then it's costly in every sense for everybody. In the hospital clinical units that we worked with on this project, we realised that there were two kinds of responses that hospitals and wards were making. The first was to have a built-in response, that is, to predict that there's going to be complexity and to have the responses ready. And just to give you an example of that, there's a very good burns unit for children in Adelaide, and they had designated a member of the clinical team as the coordinator. And whenever they got word that a child with a burn was coming down to Adelaide, that coordinator was on the phone to the primary care providers and the Royal Flying Doctor Service and whoever else was involved in looking after that patient, so that they could get as much information as they could before that patient arrived about their home situation, their family situation, who was able to come with them, and of course all the clinical information that they needed. So that was an example of a built-in response to complexity. The other kind of response, which also happens, is the reactive one, where the hospital just keeps running the business as usual systems and they react to the problems that occur after they happen. So we used the frameworks of all the factors and the insights that we'd had about dealing with complexity to develop patient journey mapping tools. Okay, now I'm going to tell you a story about one of the patient journeys that was mapped. This is complex healthcare, so it's a complicated story. Sit back and relax. So, this is a story about an Aboriginal woman who lived near Port Augusta in rural South Australia, and she had renal failure and diabetes. She became, really unwell and was transferred to the Royal Adelaide Hospital, where she stayed for 10 days. She was, and her condition was stabilised and her meds were changed and so on. There was a plan for her to be discharged on a Saturday to go to an Aboriginal step-down facility, one of Joy's hostels that had some daytime, weekday healthcare support. So she was going to stay there for the weekend and then be sorted out and travel to Port Augusta on the following Monday. But then something changed in the hospital and it was decided to discharge her on the Friday afternoon to the hostel for her to have dialysis on the Saturday morning and then travel by bus to Port Augusta later on the Saturday. This was already a complex discharge which had been planned in detail for the Saturday, and there were, further diagnostic tests and so on and drugs that needed to be got together. So they all had to be scrambled in order for her to be able to leave on the Friday. And she eventually arrived at the hostel at about 7:30 p.m. and was picked up at 7 a.m. the following morning to be taken for the dialysis session before she travelled. She was dropped at the bus stop at noon, but the bus had just left. So she waited 4 hours for the next bus and then had a 5-hour bus journey. She had no phone and her family had no phone and they didn't know that she was coming home early. The city hospital staff didn't really know how long the journey would take, and apparently no one had thought about whether she had water, food or money for the journey. Okay, it sounds like a disaster about to happen, but it turned out it wasn't disastrous. It was tough, but it wasn't disastrous. The city hospital had rung the Port Augusta dialysis unit where this woman was a regular patient on the Saturday morning and asked if they could give the woman a taxi voucher when she arrived in Port Augusta to get home. But that clinic was only open on Saturday mornings in Port Augusta. So the team discussed what they were going to do because it was too late to stop all this happening. One of the nurses drove in her own car on her own time to meet the 4 p.m. bus, and the woman wasn't on it because she'd missed it. And that nurse then went back at 9 p.m. For the next bus, and she picked her up and drove her to her home outside Port Augusta. So there are many questions about what went wrong in that patient journey, and particularly in the discharge. Why was the woman discharged early, before the planned time? Why wasn't she given a taxi voucher at the Royal Adelaide? Why wasn't the Port Augusta dialysis unit more involved in the new discharge plan? So the nurse who picked her up was able to make sure that she was still stable and get her home in good shape. The team then decided to use this case to test the patient journey mapping tools. And both the Port Augusta staff and the Royal Adelaide Hospital staff worked together to document and organise this, really complicated story. They figured out several important changes that could be made in future situations based on that story. Just to give you a feel for this, one of the important ones is the difference between being discharged home and having care transferred. So when you're discharged, you're on your own. I mean, you are in charge of your own life. The hospital has to let you go at some time. They discharge you, that's it, you're on your own. If, on the other hand, your care is transferred to another healthcare provider, then different arrangements apply. The transport tends to be better organised, and the person is not let go until the receiving unit knows all about it, has all the information and agrees that they can accept that transfer. So that was one of the big realisations that those renal staff had. They realised that they needed to organise these discharges on the basis of being transfers. You might be sitting there thinking, none of this is rocket science. It all sounds like common sense. And it is, but it is system science because, as I hope you can tell from the story, the healthcare system is set up to work in certain ways, and if your story doesn't fit into that way, then you could be in real trouble. Friday night discharges are notorious. There wouldn't be a GP in the country that doesn't complain about Friday night discharges. But they continue because that knowledge loop isn't closed. And that's what the patient journey mapping, in that interactive way, involving the staff who needed to know about it, that's the difference that the patient journey mapping can make. So just to finish off, mapping patient journeys in a structured way makes these complex patient journeys visible for the first time really to everyone who's involved in the patient's care. It identifies all the players and the gaps in the services, and it enables staff to develop solutions together. And it also provides evidence for broader system changes that might be needed even though the staff can't by themselves make those changes. These tools are now being used in practice settings, in education and in quality improvement activities in most states around Australia. Thank you.
Thanks, Judith. Thank you, Judith. I like, it's not rocket science, it's system science. So there's a challenge. And, you know, of course, there's implementation science as well. And so there's a whole lot of things that we could be thinking about and more actively doing. I do want to invite Joy up now, if you want to come up, Joy, and I won't read your bio, but other than to say that Joy and I have been long-standing colleagues and friends, and I think at the age of 20, when were you CEO of Chopin? Sorry, I should have done my research.
Early 20s.
Yes. Early 20s. So you know, this theme about leadership and driving change starts at a very early age for our people. And to have Joy as the CEO of the Aboriginal hostels here now nationally, and to share this time with us and give us her reflections today is a real privilege. So, Joy.
Thank you, thank you, Rom, and of course, Auntie Matilda, thank you for the very warm welcome to country. I feel very blessed to have the acceptance of you and your people here in Canberra, a place that I now call home, even though I'm from far north Queensland, and want to particularly acknowledge Pat and many of the other leaders in the Indigenous world, but also leaders in the policy and research spaces as well, and many friends and former colleagues in this room today. Look, I just want to make some quick observations about each of the three presentations and then offer some thoughts that you might cogitate over, think about, even challenge. Look, I thought they were fascinating, and for someone who was did their apprenticeship, if you like, in Aboriginal community control health sector for about 16 years or so, it was very interesting to hear various aspects of health in a whole sense, come together in that way. Les spoke about a piece of research that's been done over a very long period of time, distilled to 10 minutes, but that was about individual change. And often that can come at quite high costs, and funding is intermittent and it's hard to sustain, but that's where the power of change occurs. And then there's an environment in which the individual lives, works, plays out their life. In community, in organisations or attached to organisations, and then in a health system. And Cleveland spoke about the authority in the community through an organisation that was also about control, about decision making, about choice, about determination, and the methodologies that they apply to embed evidence in what they do. And the work of that research, which I know is going to be launched shortly by the wonderful Pat Anderson, signposts the way forward, particularly in health system, primary healthcare reform. And Judith touched on what I think perhaps, whilst you say it's not rocket science, it often gets forgotten and in fact could be the catalyst for transformative change in people's lives if the parts of the health system start to think more in a patient-centred way and not about themselves and the way they've always done business and business as usual. So that patient-centred approach to the way we design and deliver healthcare is crucially important to the empowerment of the individual, reinforced by organisations taking leadership in Indigenous health. So I was really encouraged. They all came from a different perspective, but really traversed much of the ground in some of the challenges that face the health system. The other thing they had in common, of course, was they all involve Aboriginal and Torres Strait Islander leadership. It's the passion, commitment and the collaboration with the research world taking their rightful place as leaders in research to bring forward more positive futures for our own people. And I think that's important. I think the mood is changing. Well, at least I feel it is. As someone who's been a bit long now, perhaps in the public sector and in the Commonwealth, but we have a government who is wanting to have these discussions, these very discussions, that's wanting to open our minds and our hearts to innovation, to do things differently, not to dismiss the evidence, use the evidence, but create the evidence. And sometimes the evidence just doesn't exist. Sometimes you start with the innovation and the evidence follows. But what I see here and through the character, the determination, the commitment of these three people, their collaborators, their organisations, the people that they work with, is that commitment to use the evidence that's currently available, but to also create the evidence through doing, through innovation, through creativity. So I think we can all take heart from that, but there are system biases and they are there. The racial bias within systems does need to be tackled. It exists in all sectors, including the health sector, even though I think we have come a long way. But I also think that we have an opportunity, particularly during this time, and I've been a little bit out of the health space for a while, but it's always nice to be invited back into it, that we do have many leaders. We have people who are committed to research, committed to evidence, committed to the translation, and I love the way that Judith spoke about, as a non-Indigenous woman who has shoulder to shoulder with Aboriginal and Torres Strait Islander people, certainly been part of many pieces of research, but being part of Indigenous peoples, meeting Indigenous people's knowledge needs. Not research for the researcher's sake or for some letters behind your name, but knowledge generation for Indigenous people's needs. And I think what's coming through is a set of principles that's embedded, that's in the DNA of the Lowitja Intitute. The 5 principles and values that Rom spoke about earlier. I think those from organisations, those who are in positions of influence, those who are developing policies, those who are reviewing policies, those who are looking at developing programs, these principles, these values, if combined and shared amongst organisations, amongst collaborators, can certainly bring about the change that we all desire. So I'm really encouraged by this first inaugural seminar presentation showcasing the real-life examples of the work of these three and their collaborators, and publishing the work and, importantly, the lessons. And I'm very much looking forward to, as I read last night, the study, the FAR study. My connections not only go back through Rom and working with Rom and many people in this room, but I also for a time was involved in some of the reforms in primary healthcare in the Northern Territory around regionalisation. And whilst we got off to a reasonably good start, it got wobbly, and now it seems to have gone a bit quiet. So, but the fact that people were committed, not ashamed of what had gone wrong, or that will just sweep in under the carpet, oh, well, we tried that, we won't try that again, or we'll do something different, actually signposting where there were barriers, signposting what we could do better. So there's this constant learning of the sector, of mistakes made, without blame, but mistakes made, barriers in the way, and opportunities to get back on a program of reform. So I'm delighted to have been invited here this morning, Rom, and see so many familiar faces and countrymen as well from my part of the world. And I thank you for the opportunity just to share some reflections of the three presentations and the potential future and the change that's in all our hands, no matter which organisation you work for and what your area of specialty is. So thank you.
Joy, thank you so much for those observations and analysis, and I know how busy you are to commit this amount of time to us. We're really grateful. Pat, I might invite you up now. Pat Anderson is our chair. Pat's heard me say this once before in the last couple of weeks, but Pat Anderson was recognised as the most influential public policy woman in this country in 2015. And it's a privilege to work with Pat. So Pat, I might...
Yeah, thanks, Ron. Thank you, Matilda, for your welcome as always, and thank you to the panel for that frank discussion about the research. There is lots written about blackfellas. We know a lot about Aboriginal health. In fact, Aboriginal and Torres Strait Islander people have been working in this space for over 50 years. We have a very intelligent workforce out there and people working in the community control sector and in government and what have you. So we know this space really, really well. I only had one job today, and that was to launch the reports that are here today and that we've so eloquently heard about. The report came from the Lowitja's Funding, Accountability and Result project. And the road is made for walking towards a better primary healthcare system for Australia's first people. And I thank everybody in Cleveland in particular for talking about this. You know, Cleveland, it was really refreshing because when we started this Lowitja, I've been involved in this now 20 years. That's the response we got from a lot of our friends and colleagues. Oh, research. We research to death. But so it was really comforting for me today, personally and professionally, to hear you say that, because it was that's sort of the first response that we did get all that time ago. This has been a huge task, and I want to acknowledge and congratulate and thank the authors for all their hard work and for their contribution to this important body of work. And I'll tell you a bit more about that in a moment. Maybe I won't because I'm running out of time here. And the authors, of course, are Judith, who's here, and Angelita Martin, I think, is also here. The other authors are Kath Brown, Edward Tilton, Jeannie Devitt, Paula Myatt, Christy Stout, Britta Pekarski, so thank them. And this project is an important part of a long line of research going back to the overburden report in 2009. Now, having given you that big rave, in fact, that was one of the reports that the Department of Health at the time did look and listen and did make some adjustments because the evidence was so compelling. It was commissioned by the Lowitja Institute to produce the evidence that will help improve primary healthcare delivery to Aboriginal and Torres Strait Islander peoples. With our government and Aboriginal community controlled health organisations, partners, the research team observed and documented planned reforms, which Joy was talking about, in primary healthcare for Aboriginal communities in the Northern Territory between 2009 and 14, and the Cape York in Queensland between 2006 and 2014. In both jurisdictions, the intention was to transition government-run clinics for Aboriginal communities to regional Aboriginal community-controlled health services, and some places did, most places didn't. These were exciting intentions, promising development of public health care for Aboriginal communities in a systemic, planned way, in accordance with long-standing policy commitments to build public health care systems based in the Aboriginal and community-controlled health sector. In spite of these policy commitments, prior to the planned reforms that were the focus of this study, transfer of services from government-run clinics to community control had been ad hoc, coming from local circumstances or as a result of other developments like the coordinated care trials. So high hopes were riding on this more planned and systemic approach. The story told in these reports is one of both achievement and disappointment. Important system resources, like a good specification of the core elements of primary health care that should be available to everyone, and the Northern Territory key performance indicators to measure the effectiveness of public health care for Aboriginal people, were developed as part of the reforms. In Cape York, Apanimapa developed an approach to local engagement and accountability within its large remote region that helped to address the expected tension between local communities' wish for self-determination and local control, and the strength of having a regional services. Some transfers of clinics were also achieved, though not on the scale intended, and the research team for this focused on understanding the why, the how and why implementation was hampered, how to do it better next time, and the next time is already happening, and what should be done. Looking forward, the report proposes 6 essential elements of change. Taken together, these elements of change provide the basis for reliable access to public health care for Aboriginal communities and for systemic development of the Aboriginal community control sector as the linchpin of regional systems of care, as well as a basis on which governments could be assured of equitable allocation of resources across the country. That's all of our thinking. These 6 elements of change would also help reset the working relationships between government funders, communities and the sector, away from a focus on contract and risk management, though both are important, and towards a focus on common goals and reciprocal accountability. This project is part of a set that includes an investigation of the benefits of working in partnership through regional planning forums, with positive findings there, the continuing burden of reporting for a large Aboriginal community control service, say in Victoria, and a small one, say in South Australia, and the theory of reciprocal accountability on which an alternative approach could be built. It is a great pleasure to launch these reports today, and I commend them to you as both a good read and as a call for action. But I think the real call for action is to get research, actually evidence-based work for good policy that's going to work. So I think that's our task. So thank you all for coming, and please stay and join us for lunch.
Thank you very much, Pat. And just reflecting on your parting words, which were really about a call to action and really influencing the policy agenda to make a real change, a real difference for our people on the ground. This is the end of the formal proceedings. And I can see that, Matilda, you're ready for a cup of tea or something, so I won't hold any of us up. But I do want to thank you, Matilda, particularly for the welcome to the lands of your ancestors and your country. The panellists who've come from Yarrabah, Cairns and Adelaide, just really grateful for your being here. It's just such a privilege to have you here. Pat, thank you for launching the report. Joy, I know how busy you are, and really your synthesis and your analysis was certainly what we'll take forward and think about more broadly. To all of you who've come today, I know this is a busy town. Sometimes you get a bit of a breather between sitting weeks, and that's great. but the work still has to go on. The invitation that Pat's extended about knowing what this knowledge base looks like, talking to us, and us, I don't mean the Lowitja Institute specifically, I mean Aboriginal, Torres Strait Islander people more generally, and our organisations. Talk to us, be proximate. Les made the point about coming and spending time. This is eternally a problem, a difficulty with policymakers and politicians. It's a challenge as well to get people out there. As Les has said, you can read all of the evidence off the page, but if you're actually sitting in Yarrabah or sitting in Kowanyama or Yuendamu or Papanya, it's a very different experience. So these are the things that are really important: proximity, place, recognising Indigenous knowledges, Indigenous leadership, knowing what evidence is there, the translation of evidence. The Lowitja Institute will not get involved in any work into the future that isn't clear about a number of those things that I mentioned, about benefit, about leadership, about impact. This is the agenda that we want to prosecute. So the conversations that we have with anyone, whether policymakers, program designers or researchers and politicians, will be around that agenda, because there's a lot of work that needs to be done into the future. We've got to get a lot more efficient about how we do that work. So thank you. Join us for some refreshments, and we'll see you again next year.